Hi everybody, a very warm welcome to joining me on this presentation. As always, I hope you are doing absolutely fantastic. Today on the video I'm going to present a business case exploring a proposed electronic document and records management system for the American Cough Institute. We are going to be talking about the institute itself, a little introduction to the business case, the business opportunities, the assumptions, a little bit about the document migration, metadata, solution alternatives, and the benefit of having such a system, and then, of course, the recommendation of what we're going to be going with. Let's talk a little bit about the institute itself. The American Cough Institute is based in Washington, D.C., and it is dedicated to the treatment of people with a cough of any origin. The Institute, ACI as we'll refer to it from now, has a highly skilled team of internationally recognized specialists that are dedicated to total patient care. And regardless of the nature of your cough, they will always be listening to you and your medical history and carefully conduct a thorough examination. We don't want to leave anything out. They utilize the newest state-of-the-art medical equipment, laboratory assessments that help them arrive at the best diagnosis when crafting a personal treatment for you. Their mission is to resolve a patient's cough and to improve the quality of life. And they do that by these 4 points here: state-of-the-art medical care, excellent customer service, respect and confidentiality, and collaborating with other specialists if needed to resolve your cough. A little bit of background on ACI. ACI's founder and director, Dr. H.E. Pennypacker, has over 50 years of cough-specific healthcare and research-related experience. Dr. Pennypacker has successfully treated over 14,527 cases of chronic and persistent cough in adults, children from all around the world. He's a diligent researcher, has numerous publications on cough, and he continues to perform regular experiments and contributing to the greater body of medical knowledge. Now, the ACI team has 10 people with there. Dr. Pennypacker at the top, Dr. Sacamano, Dr. Kel Varnson, Dr. Art Vandelay, Dr. Jay Jarmel, Dr. Franklin Delano Romansky, Dr. Beth Leichner, Dr. Ross, Dr. Sue Ellen Mishka, and Dr. Sidra Holland. Now, the executive summary, essentially of this particular case. ACI is a newly launched subsidiary of WAC. WAC currently uses paper medical charts, and so ACI will therefore make use of that current infrastructure. Since the charts are paper-based, the past 3 years of charts are stored on site in both secured and unsecured filing cabinets. We have recently implemented chart components that can be scanned into a secure cloud for easy remote retrieval by the healthcare providers that we have. Now, with this expansion going from WAC to ACI, we wanted to take a consideration of an alternative approach to classical medical records. Convenience and accessibility obviously is desire. That's something that we're trying to get after. We're also trying to get after cost effectiveness in the classification of records and also in the disposition of records. We have identified some disadvantages. They sometimes seemingly outweigh advantages, but we will do what we can to come up with the best business opportunity resolution here. Of course, this is a full examination of EDRMS system, and the key is to finding a useful, usable, effective, and efficient solution. Currently, medical records have a retention schedule as dictated by federal and state. Federal, according to HIPAA, the requirement for Medicare patients is that the healthcare provider must keep the records for at least 6 years from the original date of document creation. In Washington, D.C., it is 3 years for adult after seeing the last patient last time, and for minors, 3 years after the last time you saw the patient, or 3 years after they turn 21, whichever one is later. In Virginia, it's a little bit longer, 6 years for an adult after being seen last, and for minors, 6 years after being seen last, or 6 years after the age of 18, whichever comes later. This can be a little bit confusing, especially given that Dr. Pennypacker and his team have over 280,000 patients. So he has come up with a very simple applied medical record retention scheme. Since he sees pediatric patients, which they have the longest amount of time, according to Virginia, we have to keep it 6 years, he has come up with keeping records, all records, for the duration of 21 years in total after the last time you saw the patient. And that means that we are currently keeping records that are dating back to 1998, regardless of whether or not the patient still lives in the area, is still a patient of WAC or of ACI. It really doesn't matter. It's just an easier way for us to keep the records. Now, the key points that we're going to be discussing is that we are able to, with an EDRMS system, we're able to save time, and time is money, as you know. Dr. Pennypacker is very adamant about saving money, saving the environment, which is a big thing. We're going to be reducing the amount of paperwork that we have, potentially increases security, and it increases access as well to records, and eliminates illegibility. As you all know, doctors tend to write in the language known as chicken scratch, and that can create a difficult time to read records. Sorry for that technical glitch there. Now we will talk a little bit about the return on the investment of an EDRMS. As we know, an ROI is equal to the gain from the investment minus the cost of that investment divided by the cost of that investment. Now, when when we're implementing this system into a specialty care practice, we have to look at what the ROI will be from the particular implementation. And so we have to ask ourselves two questions. Actually, we have to really be guided by the main question here, which is, when implementing into a specialty care practice, what will the ROI be from the EHR implementation? The objectives of this research are going to be disseminated into twofold. Number one is to assess the ROI from an electronic health record or EDRMS implementation into a specialty care practice by measuring the time required to recover the cost of converting our clinics, or our institutes rather, from a paper-based environment to a electronic-based environment. And number two is to identify principal factors in affecting the realization of a positive ROI from the EDRMS implementation. Such return on investment information related to cost recovery of an EDRMS or an EHR, as they call it in the healthcare industry, electronic health record investment, would be helpful to both clinics that are considering implementation of this type, and as well to policymakers that are designing future EHR adoption that end up funding programs and policies. These such programs that are done or arranged by the federal government can offer financial incentives to healthcare establishments that wish to implement these systems. Now, the break-even point of an EHR investment is going to be defined as the number of months that it takes a clinic or a healthcare institute to recover the cost of the EHR system and other associated implemented costs with increased revenue or decreased expenses. Increases in revenue or decreases in expenses. Increases in revenue and or increases in expenses are assessed by considering net revenues during three distinct periods of time: pre-EHR, peri-EHR, and post-EHR. Of course, peri-EHR is referring to during the rollout. The pre-EHR period, as we'll discuss here, is defined as the full fiscal year that is before the implementation of the EHR system. The peri-EHR is defined as the fiscal years that is containing the EHR implementation period. In the event that the peri-EHR period covers more than one fiscal year, the net revenue is averaged over 3 fiscal years. The post-EHR period is defined as the full fiscal year following the end or completion of the peri-EHR period. So as you can see here in line item number 2, you have the cost of the EHR equals the moving on to our assumptions for our business case here. Speaking of the cost assumptions. In the first 60 days, we have determined that, well, let's just say, for a practice of our size, we have determined that it would cost roughly $410,000, a little bit more than that, 410 to 12, to implement a fully operational EDRMS, EHR system. You have kind of 6 different cost centers associated with this adoption. We have one-time hardware costs, which you can see on the right-hand side bar. Brings us in about $25,000. In green, you have annual software and maintenance cost, about $85,000. One-time hardware costs for individual physician use, that's around $70,000. That is for all 10 physicians, so it's roughly about $7,000 per physician. Labor costs for the implementation team for the practice, we're talking about nearly $28,000 that you can see in orange. The next one in red is labor costs for the implementation team of the network. That's around $48,000. And then the largest chunk of cost here is the transferring of data as a labor cost, which comes into about $153,000. So given the amount of records that we have and transferring that data over, now, that has to be done in-house. Companies do not provide a service to transfer data, partly due to a limitation on their own side for human resources, and the amount of time that it would take is probably, to charge that in man hours is people and healthcare establishments wouldn't be interested in taking on such a cost, as well as the confidentiality maintaining confidentiality of all of those records. And lastly, given that you're going to be converting all of the paper documentation over into an electronic health record, the physicians who are accustomed to those patients know those cases the best, and therefore they can. It kind of helps them review those patients as they go on. Now, there are some requirements, obviously, with getting a new system here. We have essentially 2 types of requirements: financial and non-financial. Now, for financial, we're talking about new hardware, which includes computers, printers, scanners, switches, cables, wireless local area networks, as well as making sure that we have a suitable wide area network bandwidth, particularly speaking. Then talking about software and maintenance, so you're talking about software licensing, hosting, technical support, networking, and then non-financial. So you have network implementation team, your practice implementation team, and practice and user training and data entry. That last bullet point is very important, because the user training is, well, as we've seen and as we'll talk about a little bit later, there is a large or a steep learning curve that healthcare establishments must get over before they are functioning at a level of complete comfort and 100% rather beneficial efficiency. Looking at the document migration and the strategy that we'll be using to migrate those documents. So the ACI practice currently, the practice management software happens to currently be cloud-based, although it is a legacy system. And by that I mean it was developed in the late 1970s, and it was actually the first computerized practice management system. It is called Medical Manager, and in 2001 it was actually entered into the Smithsonian's Museum of American History. Alongside the practice management software, ACI uses paper medical charts. Those all need to be converted by designated employees into a virtual format. The paper medical charts can be kept in our current storage facilities, or we can have them securely shredded, which is something that I would recommend, given that we are going to be moving all of those items to electronic format. Now, when we're talking about moving things to electronic format, we have to have a way to index those items. So, this is where metadata comes in. Metadata consists of both indexing terms and attributes. A basic view of metadata in the use of a health IT system is illustrated here. It's characterized as you have application metadata, document metadata, file system, and embedded metadata. These are the categories here, and in the following slide we will see a table that gets into the minutia of these categories here. Though metadata exists in nearly all information resources, this practice brief addresses the role that metadata plays in a patient's official record of care within an electronic record. Now, in the application metadata, this is data that's been created by the application specific to the electronically stored information that is being addressed, that is being embedded in a file and moved with the file when it is copied. Now, copying that information may alter the application metadata. With document metadata, this is properties about the file that has been stored in the file, as opposed to stored in the document content. What this actually means is that the data is not immediately viewable in the software application that's used to create or edit the document, but can be accessed via properties. You go to view properties, view file information, and examples of this include the document author, the company, the creation date, or the last date modified or revision dates. The file system metadata, this is metadata, and if I'm confusing you, let me just remind you that metadata is data about data. That's really what it is. File system metadata is metadata that's generated by the system to track demographics. We're talking about name, size, location, usage of the electronically stored information, which is stored externally from rather than embedded within the electronically stored information. And lastly, this is generally hidden. This is the embedded metadata. It is nonetheless an integral part of electronically stored information, and it is essentially comprised of, let's say, tracking changes or comments to that word processing file, notes in a presentation file, some metadata, while routinely extracted during processing and conversion for e-discovery, for example, embedded data cannot be extracted. Therefore, it's only available in the original native file. Next slide. This is the chart that I was speaking about a little bit earlier that shows some of the minutiae within the metadata categories. As you can see in application, you have metadata tags, the type of it, the length of that tag. So let's say the last name is 50 characters in length. Then you go down to document, and you can see, let's say, you can see the username, the action that was applied to that particular file, date and time, the length of time that the file was interacted with, etc. We're going to briefly cover established system weaknesses. EDRMS and EHR has been around for a little bit of some time, roughly 10 years. And in those past 10 years, some EDRMS are still half-baked and evolving. It's not all kittens and unicorns and rainbows. We have also seen a decreased utility and increased clunkiness in the system. The decrease in utility is really attributed to the very steep learning curves associated with the system. Doctors already being overworked, and also, being more so primarily concerned with patient care as opposed to being a data entry person. And the increased clunkiness really comes from the theoretical software development of the applications, as opposed to the, software development based on or coming from the field, with having doctors really inputting their thoughts in how an excellent, perfect system would work. Instead of this system being a grassroots, or instead of commonly available EDRMS systems in the healthcare industry being a grassroots approach started by doctors, it was rather top down, where it was, started by massive institutions, not necessarily in the healthcare industry, that really had no idea how the healthcare industry operates, and they just had developed these systems and said, here you go, doctors, this is what you're going to be using. Unfortunately, because doctors are very busy, they really don't have time to organize and get up to Capitol Hill and talk down or lobby the the digital establishment. The third weakness is there are massive capital costs as well as recurring costs for healthcare clinics. And these costs are hard to offset for established practices. When I say established practices, I mean practices that have been in operation for 10, 20, 30, 40, 50 years. Why is that? Because these clinics have been working a certain way for a certain amount of time. Their system works. They have grown accustomed to it, and they are also if you look at the overall operational life cycle, these physicians that are particularly in smaller solo practices or smaller group practices, they're at the end of their life cycle. They have maybe another 10 years or so wrapped in there. So dumping, let's say, $150,000 if you're a solo practitioner, or nearly $500,000 if you're a practice of 10. It's just and that's really not including the loss of productivity that you're going to be experiencing from these steep learning curves, as well as frustration and lost personal time. And lastly, as a last weakness, these new interfaces have been noted to reduce the time spent that the doctor has the time spending on practicing medicine, and rather, they end up becoming these data entry healthcare specialists, sitting there looking at the computer, trying to enter information. Time and time again, you'll end up seeing, if it's a older or a more established rather physician, you'll end up seeing them interact with patients and do their they do what they have been trained to do, which is practice medicine and be a doctor, and they'll have a younger data entry person come into the room with them and just basically scribe all of the information, but type it in the health record, in the electronic the EDRMS that they have. Now, what alternatives do we have to this solution? Solution alternative number one is to abandon an EDRMS approach altogether and continuing to use the incumbent paper system. This was not really the best idea, just because there were a lot of inefficiencies associated with this, as well as very, very long-term costs associated with keeping records based on Dr. Pennypacker's 21-year retention scheme. Alternative number two is to create a hybrid system that incorporates a SAS system and cloud-based servers, while continuing to use the legacy medical practice management system. And then alternative number three is to move over to a full platform as a service system like Greenway's Intergy EDRMS that would allow
ACI to streamline billing with integrated clearinghouse systems that would have the ability to serve multiple locations and specialties, capture and store patient information easily while providing enhanced security, and create and submit and follow up on at-risk claims while managing revenue. Now, I'll let you know that those three sentences that I just recited are directly taken from Greenway Health's site on the Intergy product. We feel that after speaking obviously with Dr. Pennypacker and his team, we feel that the optimal solution is a combination, is alternative solution number 2. Given the shortcomings that are still associated with EDRMS in the healthcare industry, we are planning to go with incorporating an SAS and a secure cloud-based server while continuing to use the legacy medical practice management system. That is the kind of the most inclusive all-around solution that all employees as well as patients can benefit somewhat from. So instead of saying, okay, we can have just one group of people in this mix benefit fully and everyone else just kind of falls behind, let's try to make everybody happy. And this is what we feel is the best solution going forward. As we go forward, Dr. Pennypacker always asks, but where does the paper go? This is something that he always jokes around about. And there's some research suggests that that there's some research that suggests that with adoption of a full EDRMS system, that doctors tend to adhere to generally accepted treatment guidelines more than if there was no EDRMS system. Now this is still in debate, and it kind of goes both ways. As we said, medicine and the healthcare industry is really divided up into a twofold split. One is the science of medicine, and 2 is the art of medicine. When you start to mess with that balance, then the overall efficacy of what a doctor does begins to go down. And by throwing this EDRMS system into the mix and having doctors really get involved with data entry and or interacting with computers, as opposed to just interacting with the patient and providing patient care, well, the jury is still out, let's just say. Generally, an EDRMS system, because you are computerizing and therefore standardizing prescription systems, there's a decreased rate of making medication mistakes. However, this again can be argued both ways. If you're paying attention to your craft, then this won't happen. Now, with the EDRMS system, there is increased transparency, which is something that doctors don't entirely find comforting. On the surface, increased transparency sounds great to all people. However, this also means that it's not just having the records available between patients and doctors, but what this means is that health insurance companies have the ability to then go in and begin auditing what a doctor does, right? And sticking their finger into the mix, saying, hey, you shouldn't have done this, you should have done that. We are only going to reimburse you now for this, but not this. For treatment A, but not for treatment B. But in terms of what the doctor was doing, the doctor said, look, I'm doing, I had a patient that was presented to me. I went to school for, 20 years, and I had a patient that came in front of me. They told me their symptoms, and so I ordered these tests in accordance to what I believe is the right way to pursue these symptoms to come to a resolution. Another benefit is increasing in record accessibility, which is great. Decreasing costs over time, also great. As we've seen since 1992 in the healthcare industry, particularly in private practices, it's particularly affected private practices harder than it has larger group practices or hospital groups. Is that since 1991, 1992, revenue has steadily decreased, as well as health insurance reimbursement to the doctors, and yet increases in expenses have occurred. So doctors are really working from behind the eight ball. They're supposed to be performing all of these miraculous things, and yet they are getting into scenarios where they're unable to sustain any type of lifestyle. It's essentially the effect here is socialized medicine. What I mean by that is that we're in a state of socialized medicine. Doctors would go to school for free, but they're paid a fixed salary generally by the state or by the country in which they work in. $100,000, $200,000, $300,000, something like this. But they don't have any student loans. Everything has been paid for by the state or by their government. Well, here in the United States, there is no, quote, socialized medicine. So you have to shell out nearly $500,000 to study to become a doctor, right? And for 10 years while you're doing your residency, you're making $20,000 a year. Talk about eating ramen. And so now you're stuck with all these bills, and then you get into an industry that the amount of money that's coming in is going down. It doesn't make any sense. So that's why decreasing costs is a good thing over time, which brings us back to the original point that if you're an established physician or an established long-term healthcare establishment, you've been around for 20, 30, 40 years, going into this EDRMS system is not that great, because you're not going to be able to recoup, you're not going to be able to recoup the ROI over the time that you're still in practicing. Alongside the lost productivity and therefore lost revenue from you trying to get this system to work. And lastly, we have general increases in data and record safety, right? If you have electronic records versus having paper records, well, there's virtually no chance of paper records or of electronic records, burning down in a fire, getting hit by a tornado, getting flooded. Of course, the data center can experience natural disasters, but these data centers usually have remote backup data centers, whether it's a warm site or another cold site, and therefore, adding to layers of data backup security. So that brings us to the end of this presentation. I hope you found it enlightening and helpful. I really enjoyed having your time, and thank you very much.